Good afternoon. My name is Dorothy Burridge, and I'm the Regional Education Coordinator with the Central East Stroke Network. And on behalf of the Central East Stroke Network, I'd like to welcome you to our webinar today, What is Community Reintegration and How Can We Better Promote It?, presented by Dr. Mary Egan. Before I turn this webinar over to Mary, just a reminder that you can submit your questions by typing them into the questions section of your control panel, and I would certainly encourage you to do that during the course of the presentation. There will be time at the end where I will be reading the questions out to Dr. Egan. So our presenter today is Dr. Egan. She's a professor in the School of Rehabilitation Sciences at the University of Ottawa. She's been at the University of Ottawa since 1996, and her research focuses on the process of returning to valued occupations, both in the presence and the absence of therapy. She is also particularly interested in critical reflection on the difficulty of enabling valued activity in a world that often does not understand the complexity of this work. So again, it gives me great pleasure to turn this presentation over to Dr. Egan. So thank you.
Thank you very much, Dorothy, and thank you for the invitation to present. I'm really excited to be speaking with everyone today. Can you hear me all right?
Yes, all is good. Thank you.
Super. Okay. So community integration, how can we better promote it? Community integration is one of the most important and underrated areas of stroke care. That is a quote from the Clinical Stroke Handbook, and I'm sure one that we would all agree with. And I would also add that it may be the most poorly understood area of stroke care. In some ways, this isn't any surprise. There's probably more focus in the early stages on early stages of stroke management, which makes perfect sense. And I think we're just getting to the point where we're starting to understand these later areas of stroke care better. The objectives of my talk today is to reflect on individual and program concepts of community reintegration, and I think to hopefully show you that the concept of personal projects might be quite useful in helping understand and helping people with community integration, and to refine an understanding of these ingredients of return to personally valued activities, social connectedness, autonomy, hope, and adaptation. So I think when you listen today, many of you will think, well, I'm already doing that. I'm already doing all those things. And I think many of you will think that, and I'm hoping just to give you some new ways to talk about it and maybe to follow up on looking for research or more research in that area. And on the other end of the spectrum, some of you may not have thought of these things before, and this might give you something else to think about and potentially some new tools. So I'd like to start off with a personal reflection. I'd like everybody to think about what does it mean for you when you're integrated into your community? What does that look like? And I'm going to put in a plug for doing things. It probably means doing things in a certain place. It may be in your home, outside your home, some other area. So just take 10 seconds to play a movie in your head about what community integration means for you in your life personally. Okay, so just think about, what are you doing? What's it like around you? Who are you with? How are you feeling? Okay, I hope that you saw one or more things in your head of you doing things, and I would imagine that if we had the ability to run all of those films, we'd see very different things. There might be some themes that connect things, but what you were doing in your heads, it was probably all very, very different. And I think that this is really important to remember. It's one of those, yes, of course, but I think it's really important to remember because we've looked quite critically at different stroke guidelines and tools, and they tend to implicitly define community reintegration. Or what we should focus on in rehab in community reintegration is getting people involved in group exercise and recreation programs. And that might be an important part of community integration for some people, but really 99% of community integration will be these things that make life interesting, valuable for you. They'll be quite different. So for me, those things that you're doing in very specific ways, in very specific contexts, sounds like personal projects. And personal projects is a concept that was developed by Brian Little, who's an emeritus professor at Carleton and Harvard, and he was interested in how personality is affected by the things we do, and vice versa. And he said, you know, he didn't have a concept to look at what we do from a psychological perspective, and so developed this idea of personal projects. So, and has continued to do research, and many people have researched personality and well-being using personal projects. So what is it exactly? Well, personal projects are defined as a set of interrelated actions leading to a goal. And they can be short-term or long-term goals. They can be concrete or abstract goals, but they have to be individually and subjectively defined. So for example, I might say, you know, some of my important projects at the moment are trying to be a better spouse, which would be a very abstract kind of thing that you could make more concrete, but it's pretty abstract and pretty long term. Or I might say that I'm, you know, helping my child trying to figure out what kind of career they want to pursue, and that would ideally be a more short term and more concrete. So just take a moment to think about your important current projects, and you might think about that a little bit today as well, later today. When we ask people, so both in research and clinically, my team has asked people about their projects, people who've experienced stroke. And I just wanted to give you an example of a way that we do it. For instance, I'd like to talk to you today about your personal projects. And personal projects are things that we want to do or need to do, things we think about doing, plan for, carry out, sometimes though not always complete. They can be short or long term. At this point, we typically give people some examples that might resonate with them. So some examples of personal projects are taking care of my garden, helping my spouse who's recovering from knee surgery, renovating the bathroom, getting out to see my brother in Thunder Bay, meeting my friends at Tim Hortons. These are all projects that we've heard of, and I find some of these are useful, and you can change those if you think that culturally or environmentally you might have different projects. I'd like you to tell me what personal projects you were working on just before your stroke, and could you tell me about the personal projects you're working on now? And lastly, could you please tell me about the personal projects you hope to work on in the future? And what we do is start a list of all these projects in those different categories, just before the stroke, currently, and hoped for in the future. So as an example, I'd like to give a shout out to three graduates from our program, Tilly Martin, Christine Abi Khalad, and Patricia Saad, who did their project looking at asking people in outpatient stroke rehab, asking them about the projects, what that might add to therapy. And so they had 3 participants. And I just want to say, if you run into any of these wonderful occupational therapists, hire them. They're fabulous. They did a great job too. And so this is an example of what these 3 participants came up with. One man said, I want to regain my driver's license. No surprise to anyone who works in outpatient rehab, that comes up a lot. Play golf and eat better. There was a woman who said she wanted to find her leg and overcome her fear of trusting her leg. And this is interesting because people do talk about impairment-related projects, and it's quite interesting the way they put them. She had a small business and liked to decorate the store window. There was a holiday coming up. That was one of her current projects. And she had a home renovation project that she was working on as well. A third man, he loved to work in the garage on his car. He played music, and he liked to hang out at a friend's garage and just hang out with the people there. So why are personal projects important? This is a lovely quote from Betzler in Brian Little's book, and he regards personal projects as providing both shape and content to a life. They shape our lives by creating commitments that provide direction and coherence to our daily lives. Coherence is achieved as a balance between striving toward project goals and settling on those that will be temporarily or permanently set aside. The content of projects provides value and a sense of meaning that will enhance well-being and stimulate both narrative and normative identity. So who we are, who we've been in our lives, what we want to do with our lives. So they're quite energizing. And why did I think, or what makes me continue to think that this is an important to talk about personal projects as you try to help people reintegrate into their lives. And this is from a study that we did. You may have seen some of these results before, where we followed people over 24 months and asked them about their personal projects starting at 6 months just after stroke, and then every 6 months after that. And we found and so we looked at, okay, when people get back into their personal projects, what's happening? What is allowing them to do this? And we found there were two key things, and one was social connection, but not in the way we typically think about it in rehab. We often think, oh, that's social support. It's somebody to drive you somewhere or someone to help you out. And yes, those things, but really it was about having, the project had these social aspects that really energized the person towards wanting to return to them again. Particularly, they wanted to return to continue belonging to that group they did the project with, and also contributing to that group. So, for instance, there was one fellow, and he was retired, but he had always been sending emails to people he worked with that were there still or had retired themselves, and there were news items and jokes and things like that. And people said to him that they'd always said to him, they always liked getting his emails, and it was interesting information. And so he wanted to start doing that again. People talk about doing their share, helping others, not being a burden, particularly for some of the home maintenance tasks. We've had a lot of people saying, you know, I like to, I wanted to get back to shoveling snow to help my wife out because she does so much for me, or I want to help a child out by taking care of their children because they're so busy. So that wanting to give back. So this energizing towards doing it could lead to trying it out if there was, if the person had a sense of being in charge, so that they could try the activity the way they wanted to, and particularly so that they could take any risks involved with doing that activity again. And for those of you who heard Doug Alexander and Allison Young at the Partnership for Stroke Recovery last week, this is a person who experienced a stroke, and his wife, and they both talked about the importance of risk and how difficult it was to you know, stand back while people tried things that seemed a bit risky. But this risk taking allowed them to try it, and they either would have success, and that would just, you know, can keep them continuing and wanting to do more, or they wouldn't have success. And this wasn't a disaster. It just helped them lower their expectations of their current performance and change things and go back at it again, which I think is what we're always trying to get people to do. But it was interesting that this happened naturally when they were experimenting with their projects. However, I think sometimes, typically, we don't work directly on reintegration and personal projects specifically, And I think that there are a number of reasons for this, and some of them, and I've listed them, and I'm going to talk about each of them in turn. So the first one is our mental models about and our guidelines for rehabilitation. So we've looked at carefully looked at the stroke guidelines, and implicitly they really direct us to work on impairment and focus on impairment, and they don't provide a lot of direction about working on personal projects. And I think that the underlying message is those things will happen as soon as the impairment is fixed. So don't worry about that. Just focus on fixing impairment. That's your job. And there is also a concern that working on those projects and adapting to allow those projects takes away valuable time from all of these, repetitions that need to be done and whatnot. And so I'd like to, and all of the impairment stuff is really important, but I'd like to suggest that we can do both. And we should do both for a couple of reasons. And the first one is that decreasing impairment alone does not lead to sustainable changes in participation, and this is well documented. It's very rare to find a study of an impairment-focused intervention that led to sustainable changes in participation. And even we know that people have subtle impairments anyway, we know that something else needs to be done in order to get people back into their valued activities. And also we feel that there is can be a reciprocal benefit for impairment, because working on your personal projects energizes and mobilizes you. You're probably going to do more walking if you're getting out to do your project, for example. It stimulates problem solving, which is necessary for cognitive, getting better cognitively, and it also protects against depression. We found that when you controlled for the level of disability, so people at the same level of disability, those who return to their personal projects are less likely to become depressed over the 2 years following stroke. So it's personal projects have that protective effect, getting back to them on depression. So the second reason that we sometimes don't focus on return to valued activities is a folk belief, and this is the belief that there is the grieving process that was outlined by Kubler-Ross has to take place before someone can return to their valued activities. This unfortunately is a folk belief. It's never been demonstrated to be actually necessary to return to valued activities. I'm not saying that people don't mourn their losses and that they don't have some difficulty understanding their deficits, but returning to valued activities can happen at the same time that these things are going on. And it's really important to focus on return to personal projects because it creates a natural experiment in which people learn about their changed abilities. You can tell them what they are, but if they see them with you while they're trying the activities, then it's going to be much more vivid for them. That failure in the presence of the supportive therapist and continued hope that they will continue to get better leads to this recalibration of expectation and further experimentation. So we're always asking people to recalibrate their expectations, and these experiments do help with that. And success leads to them setting the bar higher and continuing to work on things, including impairment. So another reason is the time limitations, and these are very, very real. People that do stroke rehab have a limited number of sessions, a limited number of time, and so they're rightly concerned about, does this take time away from what they need to be doing in rehab? However, I think that the time spent is quite valuable. It's not that long. It's probably a session. And it provides valuable information about the person that can be used in setting up impairment related activities as well. And it does also helps establish therapeutic rapport. And we are really coming to understand what therapists have known forever, is that this rapport between the patient and the therapist is so important to successful therapy. And learning about personal projects really helps you get to know the people as people. And it's also very energizing. In the project that the students did, one of the women said that talking about her projects reminded her who she was. That's what she literally said. It reminded her who she was. And it's not unusual for us to ask people about projects and come back a week later and find out that they went out and tried something. So it can be quite energizing. Oftentimes therapists will say that they don't want to discuss potentially unrealistic goals because they don't want to provide patients with false hope. And of course, this is a concern that needs to be taken seriously. However, I think the personal projects and talking about them and trying to promote them is important, because we found that lack of hope is more dangerous than audacious hope, that people can readjust and do readjust all the time. But if what they're hearing from therapists is, and they can quite easily interpret what they're hearing from therapists as being, there's no hope for you ever doing this, that's more dangerous. People are often more adaptable and resourceful than we could have imagined. As I said, it's not unusual for us to, come back to a session and find out that someone tried something over the weekend and it worked well. And experimentation often allows some form of re-engagement that, despite impairment, that we couldn't have imagined. Another concern of therapists is risk. Of course, this is an important concern. We certainly don't want anybody to become worse because of something they tried on our suggestion or with our encouragement. But people, and I think, though, the problem is that we tend to think that our job is to tell people what's safe and unsafe, and really be convincing through our talk. And this really isn't how anyone learns, and it's easily, and we also think it's best not to encourage anything that we think might be risky. However, the experiential learning that comes with trying personal projects is more effective than talk. People can see where they're having a problem, and I'm thinking about someone that might want to get back to cooking, and can imagine that. And you might say to them, well, really you shouldn't be putting anything in the oven because your balance is so poor you're going to fall over. And that may or may not convince them. But if you're trying out that activity in therapy and they see with you that they're just about to lose their balance, and they look at you and go, oh gosh, thank goodness you were here, you caught me. I guess I shouldn't be doing this by myself right now in this way. It's probably a much more effective way to improve safety. This idea that we don't have, there is an idea sort of floating around out there that we don't have effective or efficient interventions for helping people return to personal projects. And I think, and the implicit idea from the guidelines is that your job as a therapist really is to just focus on impairment, and everything else will follow. And that's because the guidelines are set up kind of biomedically, and that makes sense because of the way they were set up. But we can go further now and look at some different ways of thinking about reintegration and personal projects. And there are effective and efficient interventions that do exist to help with this. We're doing a review right now. We think there are about 15 or 30 differently named interventions out there, but two that seem to be floating to the top are occupational performance coaching and cognitive orientation to occupational performance. And probably many of you have had some experience with these interventions, but they do help people return to their valued activities, and they do it fairly efficiently, so within about 10 sessions. So I hope that I've created some kind of buzz around that it does make sense to look at valued activities, personal projects directly. I'd like to talk briefly about some of the things that we've learned in asking people about their personal projects, both in research and in practice. And the first one is to avoid preset categories. When you're asking, just define what a project is and really open it wide up, because you will hear about some things that people might not have told you about if you are looking at categories. The other thing is to provide potentially relevant examples for them, but to make them very broad, so that again, that person can really think quite broadly about the things and talk to you about the things that they might want to do. We find asking about past, present, and future hoped for projects is quite important. It gives the person the sense that you as a therapist are taking all of these things seriously and that there's hope for all of them, and also gives you a much clearer and broader picture of who that person is and what they typically do. The fourth thing, is trickiest one, is to listen carefully and deal with your own anxiety. I just wanted to give you an example of this. Dorothy Kessler, who's at Queen's University, in her research on occupational performance coaching, she starts with personal projects, and we look together at some transcripts of a therapist talking to a patient about personal projects, again, 6 months after stroke. And this therapist, very committed to client-centered goals, very experienced, a lot of confidence. And when you listen to this tape, you can hear how difficult it is to just be quiet as the person is talking about things that you might consider kind of risky or unrealistic. And so this was really an eye-opener for us. So I would say just allow time for a lot of silence, and in your own mind, just listen for that voice of, oh my gosh, what's this person talking about? We're never going to be able to do this. I've got to move this person along. Just be able to listen to that little voice and just let it move on and just keep listening. We've also found that, I'm sure a lot of you do the COPM, and I think that's wonderful. And we found that discussion of personal projects before the COPM can help broaden the goals a bit, and in particular deepen the goals a bit more to give more a sense of the context in which those things that the person wants to get back to are done. So I hope that I have sold the idea of personal projects being a concept that might help us better understand and facilitate community reintegration. And also maybe to give you a sense that it does help give more information that might not be covered under broader participation measures. And also to underline the idea that others' positive attitudes and behaviors are especially crucial as people try to re-engage in their valued activities in their communities. So allowing for those experiments, allowing for that risk-taking. I wanted to mention briefly two issues that tend to commonly inhibit personal projects. If these things are present, they're going to get in the way, so you just need to listen for them. And the first one is medical issues that haven't been identified or dealt with. So if you're hearing that someone tried something and they decided that they were going to stop because maybe they're just getting too old for it, it was just too much. What we found is generally when people talk this way, there's often some kind of underlying medical cardiovascular, kidney problem, something like that, something that hasn't been dealt with medically, and it's not just aging, as we in the anti-ageism business like to remember. The other one is low income, very low income. So Katrina Sauvé-Schenk, who's a professor also at Ottawa U, looked very closely at issues related to very low income. So she worked very closely with people who had incomes of under $20,000 a year. and found that in these circumstances, the quest for sustainable housing, medication, and transportation really took all the time and energy and didn't allow anything left for pursuing personal projects, or actually got in the way of some of the things that needed to happen with personal projects. So if this is a situation the person's living in, it's really good to help them connect with the resources to attain some kind of stable income, or it's just going to be impossible to get any further with personal projects. So a quick resource for personal projects, Brian Little has a wonderful website that takes you through lots of information about personal projects, and also gives some tools. Now, I think there are about 6 tools. I've talked to Brian Little about this. He said, you don't have to use the tools the way that we provide them here. You can adapt them. One of the adaptations that we've made is asking about past, present, and future projects. There's all kinds of things you can rate. You don't have to do those ratings. You can just come up with a list of personal projects, and that's quite fine. So this seems to be a lot to think about, and I've really whipped right through it. But I think that just asking about personal projects seems to be a really great place to start, and I'm really looking forward to your questions. And if you come up with one after you walk away, please email me. I'd love to chat further about it.
So thank you very much, Dr. Egan, for that very interesting talk. We do have a question for you, and the individual has identified and commented that they definitely agree with the value of the concept, but when is the best time to introduce this with patients? The concern is, such challenging times in terms of within patients, their decreasing length of stay, the increasing complexity of the patient. Sometimes it's difficult to address, or feels like it's difficult to address these topics. And patients themselves are feeling quite overwhelmed with their current condition, that they can't always necessarily see beyond the present and their present limitations. So interested in your thoughts on that.
What a great question. Thank you very much. I'm sure a lot of people are thinking the same thing. And that's something that we have thought about a lot. And I think you can, I really hope to give you the idea that this is quite an adaptable concept, and you can build tools around it that are quite different. So in an inpatient setting, you might have other ideas, but I would suggest that, maybe even when somebody's working on a certain activity, that they don't need to focus, that not like dressing, something you need to focus on, but if something, okay, I'm blathering now, I'm going to calm down. And webinars are so exciting. So the, it doesn't take a long time, and if in a very acute setting, it can be looked at in the part of the sort of getting to know you, to take 15 minutes to tell me, tell us about some of the things that you were doing before you had your stroke, some of the activities that were, some of the we talk about projects, some of the projects that were important to you, and I'm really asking you this because I just want to get to know you a little bit better, and I think that could be quite helpful, quite a helpful sort of 15, 20, 30 minutes spent to get a sense of this person's life and the context and the things that are important to them, that the practice guidelines tell you to do. They don't tell you how to do it, but I think this is a very efficient window into that, because they'll also tell you about, the other people that were doing these things with them, and you'll hear a lot. My favorite project so far was taking care of the sheep, and I'm thinking, I wonder if I would have heard about this if I was just sticking to my more standard questions. So that I would say in a very acute setting, and you don't have to come up with a whole list, but it's like, tell me 1 or 2 things, 1 or 2 projects that were really important, because I just want to get to know you a bit better. I think in a rehab setting, I think it could be extremely helpful again, to get to know that person a bit better, to establish the relationship, to have a better sense of the context they're going back to and some of the things that they are thinking about doing, and just say, I'm not sure whether we can, when in a rehab setting, clearly you're not going to be doing some of those very specific community-based thing, but you might want what you are doing to speak to those things. We're going to practice, walking in this, this will, if your shopping is your thing, this will, help you as you're shopping. You guys are going to have a way better understanding of this than I do, but so that kind of thing. And then I think in outpatients or home therapy, and I've had the very great privilege of visiting 4 exemplary outpatient or community-based programs over the last little while, and people really are doing this. They really are asking about what is really important for you to get back to. Tell me about what you were doing, what you want to do. And it just makes such a big difference. And particularly, I'm thinking about a situation where somebody might come in for driving, for example, which is really, really important, but you can't, and you work really hard to get there. But this also gives you something else that, so everything is not hinged on returning to driving, and there might be some entries into community reintegration. So you've found this thing the person is going to do, and so it gives you a way to work on alternate forms of transportation while the person is continuing to try to get their license back. I hope that addresses that question.
So we have another comment for you. Another person indicates, thank you for providing another lens on community reintegration. I love the personal projects approach to help persons with stroke live fully after a stroke. And they'd like to ask whether you feel that there is still a role for developing key community programs to support reintegration. Particularly in their region, they are currently looking at some core programs such as supportive conversations groups, exercise, support groups, peer support, etc., which persons with stroke seem to value after discharge from the hospital. And they're feeling that the combination of personal projects and having access to some of these key programs in the community would be a winning combo to maximize reintegration. So interested in your thoughts on that.
Oh, what a great comment. I am totally on board with that. I think that is a really good approach. And particularly because, yeah, absolutely. We definitely know that these programs are just vital for people. But they're not for everyone. For different reasons and very complex reasons, but for many people, they're so important. And some of the most successful ones, I think, have allowed for that overlap too, so that in your conversation group, you're also talking about, well, how am I other ways that are other groups I'm going to use these tools with, and I, going across the province, I've seen that as well, that there's that that's built in. So I love the idea of going forward and continuing to build these really important programs, while also making sure that the services look at personal projects for everyone as well.
So another comment, thanks for a great presentation. Would you differentiate between personal passions and personal projects? Would you say that asking patients about their personal passions is the same as asking about personal projects? Because this individual asks, if people think about projects as more time limited and concrete?
I think that's a really good way of looking at it. I think it again that what I love about personal projects is um, how it really helps you see the uniqueness of that thing for the person. So somebody might say that they're passionate about music, and a good therapist would always dig right for the uniqueness of that and the context and all that stuff. But this can be I think the personal projects can be helpful as you're becoming sort of aware of how to dig for that, and also yeah, that concreteness, but for sure, and it's probably the projects that you're passionate about that you really want to grasp onto with your patients.
Another comment is much of what you have spoken about sounds like the assessment and treatment that recreation therapists do in their work on return to community. When do you recommend a referral to recreation therapy to start this work?
Wow, what a great question. Yes, and shout out to all the recreation therapists. Um, yeah, I think that, I think that is a really good research question. Um, I I have my personal ideas, but I don't have any real empirical evidence to support that. But I personally feel that in in if somebody asked me where would you like to see all the services that we have, like if mobilized, I'd love to say after hospital discharge. And so if there was limited resources, that's where I'd love to see them, because again, it's so contextualized, eh? Um, but again, I don't have any empirical evidence for that, and just a gut feeling. But I love it as a research question.
So we don't have any more questions in the box yet. Um, just a last call. If anyone else has any comments or questions for Dr. Egan, that would be great. I just wanted to my comment was I really liked your quote about the lack of hope is more dangerous than audacious hope, and I think that's something that that will stick with me in the future. So thank you for that quote.
Thank you so much, Dorothy. I really enjoyed giving the webinar, and I hope to have a chance to talk to people about this in the future.
So we do have one other question, and I apologize, it's something you and I didn't discuss ahead of time. We have been asked if you would be willing to share either your presentation or any other handouts, and we can certainly put them in the PDF version and send them out to all attendees. Just not sure how you feel about that.
Sure. Oh, absolutely. And will send you, Dorothy, a form that we use, and I want to stress that this isn't about the form, and I want to stress the importance of making the examples quite relevant. I'm thinking of to the locale, but I will send those along for you to include.
Okay, wonderful. Thank you. So that is something that I will send out to everyone who's attended the webinar today. We can certainly make that available after. So thank you. So not seeing any other questions appearing, I would like to take this opportunity to thank you, Dr. Egan, for presenting today. And also I'd like to thank everyone who attended, participated in today's webinar. I would ask that you take a few minutes of your time to answer the survey that will appear on completion of the webinar, or you will receive it in your email. And again, I'd like to wish everyone a good day, and also to wish everyone a happy Thanksgiving as this weekend is coming. So Again, thank you and have a great day, and we'll end our webinar here. So thank you and goodbye.